Hello, everyone. Welcome back to our weekly meeting. This is our 72nd consecutive meeting on COVID. We have our chief speaker with us, Dr. Nidhi Dhawan, who is the who's the associate medical director of ENT and the head of the safety committee in Shroff Charity Eye Hospital in Daryaganj. She has been, carrying the legacy forward, and she has been educating all of us. And as she always says, she's also been educating herself. So, we're learning new things every day, and we are continuing our series on fever. We've had a few sessions on fever already, and today we're going to be going into depth about enteric fever, along with the COVID update that she usually does with us. So without much delay, I would hand it over to Dr. Nidhi to conduct the session. Over to you, Dr. Nidhi.
Thank you, Dr. Meenakshi. Today, I think it's a little more than the usual number. I think enteric is interesting enough for people because enteric is endemic in India and poses its own problems. So without further delay, let's start. We will initially just update about the world situation and then move on to enteric. So talking about the COVID situation in the world, we have been hearing a lot about how many cases India has had, whether we are underreporting, and whether our mortality data can even be trusted. But these figures from a news channel have gone into depth and found that we have done pretty well. And Kerala is at the top of the states which has performed the best. Despite its high numbers, its mortality is the least. Coming from worldometers, you can still see that even better than our own news channel, they report us at 1.3%, whereas Mexico tops the charts at 7.6% mortality. Encouraging to see the 7-day averages are falling even further. We are seeing, last week we saw that they had fallen to just around 30,000. This week they have fallen to 24,000 by the end of last week. Daily new cases globally are also beginning to show a downtrend. Again, a very encouraging sign. Daily deaths have finally begun to catch up with the daily new cases, falling. They were not falling till the last week. In the world, the top 4 countries are of interest: USA, India. Brazil is not reporting so much, but UK. These countries are still reporting in the region of 15 to 30,000 cases daily. Interestingly, UK has nearly 80% vaccination with AstraZeneca and yet is reporting about 30,000, largely driven by Delta. Again, if we go by the WHO data, that bottom blue, barely visible spot is Africa. Least vaccination, least number of cases, least number of variants. Maximum immunocompromised population, they are in the grip of a AIDS epidemic, and yet they haven't suffered COVID as much as the US has. There might be some biological factors to this also. US is also in the epidemic of obesity, and obesity has been proven to predispose to COVID. So we finally see the US numbers steeply falling, Brazil falling, UK kind of plateauing out, but showing a downward trend, India falling. Again, the Johns Hopkins heat chart, if you see, Africa, very little spots, and almost none in the sub-Saharan Africa. The ivermectin belt, as I like to call it. US, majorly Europe, parts of Middle East, still having some cases. South of India still having some big red dots, but otherwise situation is globally improving. Just a recap, yes, every country is now showing a downtrend. If you see the cumulative cases, Russia, US, Brazil have shown some darker days. Africa, newer cases you see is almost white or light yellow, none, and with the least vaccination rates. Maybe ivermectin. And we'll go on to enteric fever now. So enteric fever in India poses specific challenges. For the last nearly a decade, enteric fever has been steadily rising. It has almost tripled its numbers in the last 10 years. And this is despite good antibiotic and vaccine availability in the market. There was a felt need for standardized India-specific guidelines. And then an enteric conclave was held in November 2015, which came up with the API guidelines for management of enteric fever in India. I'm going to be majorly using these updated Indian guidelines, but I'm also going to be referring to a few papers which talk about pathogenesis and pathogenetic logic of using certain medicines. So the link is at the bottom of this slide if you want to read that paper, very involved and complete paper. Interestingly, this paper pointed out that enteric can be seen by GPs, internists, and gastroenterologists. Even though the guidelines are given by internists and gastroenterologists, it's actually the GPs who see the bulk of enteric in India. So this enteric conclave included the GPs, heard their take on enteric, included the clinical picture as they begin to see it, and came up with these guidelines. Very interesting conclave they had. This is the paper I'm going to be using for pathogenetic mechanisms of COVID and how enteric and how it exploits the human immune system. Interestingly, enteric evades innate immunity. I mean, innate immunity is something that gets triggered by anything that is perceived as foreign, even if it is not very harmful. But Salmonella can evade even innate immunity. This study used human intestinal tissue samples and mini gut organoids grown from intestinal tissue of biopsy specimens from suffering patients, and used these organoids to figure out what was happening in Salmonella infections. So Salmonella activates and exploits certain basic cellular mechanisms. It rearranges the cytoskeleton. It polarizes the cytokine release and uncouples it from mRNA translation. So polarized means that it releases cytokines from the apical end of the intestinal mucosa, preventing the recognition of infected macrophages and monocytes, which then travel through the loosened tight junctions into the intracellular spaces. It also hampers host immune defense system by downregulating genes for antigen sampling and presentation. The interesting thing is, if Salmonella is doing it in the human gut, how do commensals survive? Commensals also follow the principle of immune evasion. They're not recognized as foreign. They're recognized as self. They manipulate glucose homeostasis, some other metabolic pathways, and oxidative pathways. So Salmonella exploits not only those, but also has evolved to be more virulent through some genetic enhancements. And these are natural. It's a natural gain of function in operation. So enteric fevers classically include typhoid and paratyphoid fevers. These are caused by gram-negative bacteria, the Salmonella. It's a gram-negative rod which is flagellated. And flagella have a special place in how the bacteria uses pathogenetic mechanisms. Typhoid is caused by Salmonella enterica serovar typhi, and paratyphoid is caused by serovars paratyphi A or Schott-Millerii, which is paratyphi B, or even Hirschfeldi, which is paratyphi C. The typhi to paratyphi ratios range in the range of 10:1. So typhoid is by far more common than paratyphoid. The most common globally is a paratyphoid A or typhoid, whereas B and C are more common in Europe. The normal gut has enough microbiota to push out Salmonella and not enter the intestinal epithelium. Misuse and overuse of antibiotics, underlying inflammation due to other reasons, use of antacids are all reasons which predispose a patient to Salmonella infection. Once the Salmonella is present, it can take up to 2 weeks to incubate and produce clinical features, but the gut changes start within 2 hours. Now, this is interesting. So, if you have ingested a contaminated food item, you will not realize it till it is too late. So food hygiene and hand hygiene become of paramount importance in public health measures to prevent outbreaks of Salmonella. Systemic bacteremia with limited or no GE symptoms would occur in this first 2 weeks, 7 to 10 days of incubation period. Comparative genomics have revealed about 480 Salmonella typhimurium unique genes and 600 unique genes which allow increased pathogenicity of Salmonella typhi. Notably, the Salmonella typhi genetic acquisitions are specifically enhancing its pathogenicity. So these are the specific pathogenicity islands 1 and 2. There are 2 human serine threonine kinases, and there is a gene for typhoid toxin, which are all enhancing the toxicity of enteric. Current vaccination requires multiple dosing and is about 62 to 96% effective. Now compare this with COVID, where the mRNA vaccines are effective to the tune of, supposedly, to the tune of 92 to 94%. We do not hesitate to use typhoid vaccines, but we see a lot of vaccine hesitancy towards COVID. It is time to tell people that COVID vaccination is important and is contributory to our being rid of COVID in the long term. Similarly, for enteric, the Universal Immunization Program of India includes typhoid vaccines for children in the school-going age group, because studies have found that even children as young as 1 to 3 year old, preschoolers, have enough carriage, almost as much as school-going children from 4 to 15-year-old. In the pathogenicity, there is significant down-regulation of some defense mechanisms within the gut, which occurs within 2 hours of infection. These involve down-regulating B-cell signaling, coordination between innate and adaptive systems. This is mediated via nuclear factor kappa beta. Now, I don't know because I haven't found any studies, but I have a conjecture that ivermectin might work here also because it affects the nuclear factor kappa beta pathway. The cell signaling pathways, both the JAK-STAT as well as the nuclear factor kappa beta are involved in downregulated mechanisms. And there are several cellular signaling pathways which come into play. This data indicates that Salmonella typhi can hinder the activation of innate immune response of the gut lining within the first 2 hours of presentation. It evades recognition by pattern recognition receptors as foreign. Just as there are some down-regulated genes, there are some up-regulated genes early in the infection, which also decrease the immune response. So the nuanced dance between the genes which should have been upregulated get downregulated. Those that should have been downregulated get upregulated. These are the eukaryotic serine and threonine kinases, which allow the bacterium to break tight junctions and enter intercellular spaces. Acetyl transferases, which can cause both the diarrhea as well as the constipation, but majorly the abdominal discomfort. Inositol monophosphatase, which protect the bacteria-laden vesicles which are inside the cells, and the components of general secretory pathways. Interestingly, SP1 special pathogenesis island 1 encoded virulence genes are upregulated. Not only are they affecting the host, but they're also using the bacterial genome to upregulate virulence. If you see here, the nuclear factor kappa beta is at the center of most of the pathogenic effects that Salmonella has, including free radical oxygen and nitric oxide generation, the CD83, the CXCR4, which we are seeing in COVID also, the complement pathways, CCL5 and CCL19. These are all parts of the junction between innate and acquired immunity, adaptive immunity. So there is uncoupling from transcription replenishment of cytokines. The cytokines that get released do not and cannot work on the innate immune cells to promote pattern recognition and recognize Salmonella. These are mediated by the blocked MAP as well as the nuclear factor kappa beta pathways. So there are limited GI symptoms in the early phase. This is also a clinical indicator that there is very limited immune activation. So if there was an immune activation, you would get to know that you have been infected and take early enough steps. This is very important because the Salmonella has enhanced over a period of time, evolved to evade innate immunity. And the deeper we go into the pathogenesis of Salmonella, the better we will know how how threatened we are by natural gain of function, and how our immune system needs to be responding to certain things. So the Salmonella typhi evades immune response, even the innate immunity, which is a very unique behavior among parasites. The polysaccharide capsule VI, virulence enhancer, that prevents recognition by pattern receptors. It evades innate immunity by downregulation and non-expression of genes, by uncoupling of cytokine release, and by exploitation of cytoskeletal assembly. The inositol assembly protects the salmonella within the cytoplasmic intracellular vesicles. So it prevents autophagy and release of the salmonella antigens for MHC1 and 2. The MHC2 associated NADPH oxidase as well as nitric oxide synthase are downregulated, which further protects the bacterium even in the intercellular phase. So what really is the clinical syndrome of enteric? Typically, about week to 2 weeks after ingestion, there would be fever, headache, variable cough, splenomegaly, leukopenia, constipation or diarrhea, depending on what is the level of inflammation in the gut, and intense fatigue. The API guidelines talk about certain definitions of confirmed, probable, and chronic enteric. And these definitions are important because most of them rely on cultures rather than Vidal and sero testing. They also concede that GPs usually use clinical features, sero testing, and CBC for their diagnosis. Cultures are rare in the general practice setting. However, Salmonella can practically be confirmed from even the appearance on the culture media. So in the nutrient broth, there is uniform turbidity after overnight growth. On the nutrient agar, there are grayish-white circular colonies, which are about 2 to 3 millimeters in size. On blood agar, there are convex, circular, smooth, glistening colonies. On McConkey agar, these colonies are pale yellow and colorless, and they might be 1 to 3 millimeter in diameter. Wilson-Blair bismuth sulfate medium is specific for Salmonella and gives us black metallic looking colonies. XLD agar has dramatic red colonies with a black center, looks like flowers. Deoxycholate citrate agar shows colorless transparent colonies within 24 hours. So if we see the culture, if you are able to plate McConkey, nutrient, and XLD, you practically don't have to do anything else. So now we'll come to what API recommendations of 2015 say, and why it is important to be aware of the current situation. The main conclusions from this conclave were that there is a high burden of disease even in the preschool children, but it is almost equal in the preschool and school-going kids up to the age of 15. The importance of food hygiene as a public health measure has been emphasized in this paper, and vaccination is recommended to be universal. They also concluded that about 57% of the isolates in the study were resistant to nalidixic acid, and about additional 2% were specifically resistant to ciprofloxacin. Their conclusion was that nalidixic acid resistance actually indicates ciprofloxacin resistance or fluoroquinolone resistance. So nearly 60% cultures are resistant to fluoroquinolones. That may be because of overuse and misuse of antibiotics in the last decade or two. 7% are even resistant to trimethoprim, ampicillin, and chloramphenicol, which used to be earlier the gold standard of treatment. The MDR has doubled between 1999 to 2005. The importance of responsible use of antibiotics and antibiotic stewardship at our level cannot be overemphasized. We must remember to use as narrow a coverage as we can, given the clinical situation we encounter. We probably should do another talk on the stepladder approach to antibiotic treatment, where we can see which antibiotics to use at what levels of confirmation. So typically, the enteric fever has a step ladder pattern. Fever goes up a notch every day and shows that sawtooth appearance. It lasts for about 15 days. And classically, you will find the clinical course can be roughly divided into the asymptomatic incubation phase at week 1, the step ladder fever with bacteremia, classical rose spots, splenomegaly, and abdominal discomfort in week 2. And in the week 3, the stage of inflammation and complications that need to be cared for. Diagnostically, GPs generally use clinical criteria. The dull frontal headache, classical fever pattern, constipation in the early phase, which is due to the Peyer's patches being invaded with monocytes, causing intestinal luminal narrowing and edema, which later on, as the necrosis sets in, becomes a diarrhea, which might even be bloody or pea soup. The salmon-colored blanching rash on chest, abdomen, and back. Now, this has to be differentiated from dengue. The fever pattern in dengue is very different. Rashes look quite different. Dengue will have the positive tourniquet test, whereas enteric will have the positive blanching test. Though even the dengue rashes will blanch, but they will increase on applying the tourniquet, whereas the enteric do not increase on applying the tourniquet. Loss of appetite, fatigue are common to both. Interestingly, in dengue, you will find relative tachycardia, whereas in enteric, you will find relative bradycardia with a thready pulse. Blood culture, according to the API, is 100% specific, but, and importantly, 25 to 30 ml blood in adults and about 15 ml blood in children is needed for adequate sampling. This should be taken at the time of chills before antibiotic treatment has been initiated and should be repeated 1 hour later and then again 24 hours later. Now, this is the recommendation. So this is one of those situations where you have to balance the nuanced dance between when you start the antibiotics and closely monitor the patient for improving or deteriorating clinical course. So in the labs, generally enteric is associated with mild anemia, normal to low TLC, relative lymphocytosis. Whereas in COVID, we are seeing relative lymphopenia. It can have either eosinophilia or decreased eosinophil count. It can have either normal, low, or decreased thrombocytosis. There is subclinical DIC that would be related to how the platelets are in the course of the illness. Most of these findings, it is assumed, are because of early bone marrow suppression as well as hemophagocytosis, rather than the direct effect of the enteric bacterium. So antibiotic sensitivity in vivo for Salmonella found according to this paper showed that there is increasing resistance to fluoroquinolones, and cefixime and ceftriaxone or cefotoxime are still approaching 100% and would preferably be used as first line in these cases. Cefixime and cefpodoxime also, though it is not mentioned in this, they have mentioned it in the paper. Cefpodoxime also has been found to be equally effective. Out of personal experience, I feel cefpodoxime is very bitter. Cefixime is very palatable. It's almost like children will demand that if they are given cefixime. So in case you're dosing children, it would be preferable perhaps to use cefixime. And in adults, either one of the two should be fine. There is a cefixime clavulinate combination, which comes by the brand name, I think, Mortega, which is again an improvement and can be used because Salmonella's enhanced attributes include deactivation also. So in the primary care practice, what does a GP generally rely on? They rely on the clinical picture along with Vidal, CBC, and perhaps typhidot. They say that blood culture at the GP level is expensive, tedious. You have to take 25 to 30 ml of blood. So not many GPs prefer to do that. And it takes at least 48 hours to report, which would be delaying the treatment by a critical 48 hours. Vidal test takes about 18 to 20 hours to report. It is relatively cheap, easy to perform, but we must show rising titers 10 to 14 days apart for that first diagnosis of confirmed enteric. The Vidal uses O and H antibodies. The O antibodies appear within the first week and should show a titer of 1 to 80 or a higher. The H antibodies appear in 10 to 12 days and must show a titer of 1:160 or higher. O is quick to rise and quick to fall. H persists for a little longer. So what is typhidot? Typhidot is a rapid dot enzyme immunoassay and gives you the result in 3 to 5 hours. This uses IgG or IgM antibody specific to outer membrane protein. So it is a specific test. It is quick to perform and it is easy. It's like done on a slide. So typhidot is a good alternative to blood culture and it is specific. Also, because of antibiotic misuse, perhaps contamination of the sample by staff, or inadequate or inappropriate sampling. You have to do it at the right time, at the time of chills and 1 hour later. You could have blood cultures which become falsely negative. And these false negative rises with each week. So what are the investigations that the API recommends according to the week of presentation? Within the first week, they say that CBC would probably show decreased eosinophil count. Blood culture is recommended. Typhi-DOT or Typhi-DOT-M is recommended. And the first baseline Vidal should be done. The non-feasible tests that they do in tertiary care settings include bone marrow cultures, which are very difficult for both the patient and the doctor. Duodenal aspirate cultures requires a tertiary care GE setup, dipstick and PCR tests. These are non-feasible, considered non-feasible at GP level. In the second week, the CBC will show leukocytosis. Blood culture, stool culture will be positive. Typhi-DOT will be positive. And Vidal will show a rise. If you have missed the Vidal in the first week, then this is the time to get the basal Vidal. After this, you will not know what was the baseline. In the third week, most of the features of full-blown enteric will be seen that we have discussed. Ultrasound abdomen will show hepatosplenomegaly. Blood culture will be positive, stool culture will be positive, and Vidal titers will be very, very, very high. In the fourth week, the hemat picture will start returning to normal or will show frank DIC. Ultrasound abdomen will show hepatosplenomegaly. Blood culture, stool culture will stay positive if the patient is moving towards complication or towards chronic carrier stage. The Vidal titers are still very high. Typhi-DOT is positive. The treatment algorithms, and I think when you go back to this this live later on, you can take screenshots of this because I found this very instructive. They have given what is the recommended dose of each antibiotic depending on sensitivity parameters in adults and in children. Remember, in children, we would want to avoid quinolones if at all we can. So in children, we should prefer azithromycin and cefixime. In uncomplicated, sensitive, responding cases, fluoroquinolones, ciproflox or Oflox, or third generation cephalosporins like cefixime. In non-responders, you could try chloramphenicol or amoxicillin and repeat culture. Children, cefixime is the first line. In non-responder or drug resistant, take chloramphenicol and check again. So these are very detailed criteria of how much to use, what to use, and at what stage to use. If I were to summarize this in 2 lines, use cefixime in children, use ceftriaxone or cefpodoxime in adults, and if you find drug resistance, then switch to second line treatment. What are the red flag symptoms? If there is increasing non-remitting headache, vomiting, seizures, altered state of consciousness, papilledema, or even focal neurological deficits, this patient needs urgent hospitalization. Chest pain, palpitations, new murmurs, or change in characteristic of a previous murmur, cardiac arrhythmias indicate either myocarditis or pericardial effusion. Immediately hospitalize this patient. Chills, unremitting cough with or without sputum, pleuritic pain, coarse crackles, and bronchial breathing, again requires immediate urgent hospitalization. Musculoskeletal system, local tenderness, rigidity, pain giving rise to loss of functionality, acute swelling in any joint, with or without effusion. GI jaundice is rare, but if it happens, it is an indicator for immediate hospitalization. Nausea, vomiting, and abdominal pain. Interestingly, salmonella, once it gets disseminated, will even appear in the urine. Dysuria, increased frequency, suprapubic or pelvic discomfort, again a red flag for enteric. In uncomplicated enteric fever, which is responder non-multi-drug resistant or extremely drug resistant, MDR or XDR, these are emerging in particularly Pakistan and India, where I think misuse and overuse of antibiotics is quite rampant. And this is something that our stewardship program should strongly discourage. Azithromycin in uncomplicated responders is the ideal. It covers about 94% with cure rate of 94%. And mean day of response would be the third day. So if you look at the comparison between azithromycin and ceftriaxone, you see that azithromycin is quite comparable and requires very convenient dosing, very quick response, third day, and once a day dosing. So the most dreaded complication of enteric fever is intestinal perforation with peritonitis. This carries nearly 100% fatality. Why this is important is because in view of other complications, central nervous system, cardiac, urinary, we might miss the clinical signs of a perforation. So fever is 100% present, high grade in case of perforation. Abdominal pain is 100% there. There is distension, dehydration, and constipation because this patient is going into ileus or immotile gut. There is vomiting, there are signs of shock, and there might be related chest findings. The extra-intestinal complications are not that common, but are significant. And in fact, when I was talking to my husband over this, he said he had enteric in childhood and he remembers feeling delirious and confused. So it is important to know that these things can happen at any age, and especially in children, we need to be mindful of complicated course. The prevalence of various neurological manifestations. So the commonest is delirium, followed by, and that's nearly 50%, followed by headache, encephalitis, psychiatric manifestations, confusion, ataxia, meningitis, and even extrapyramidal symptoms, which is significant. The clinical features of delirium, commonest is restlessness, followed by confusion. The hematological complications are also very significant and must be looked for. There is, in the initial stages, subclinical DIC, but this will quickly become a full-fledged DIC if we do not take adequate action. So before the patient goes into shock, we must do the fluid and electrolyte balance. What is the reason for relapsing enteric fever or chronic carrier enteric fever? Largely misuse of antibiotics, probably inadequate treatment, or if in the endemic area, we are unfortunate and encounter initial infection with multi-drug resistant or extremely drug resistant enteric. Chronic carriers are defined as those who continue to shed salmonella even after 1 year of initial infection. WHO says that the virulence antibody test, the VI, is diagnostic for chronic carrier stage and recommends, and this is important, recommends ciprofloxacin 750 milligrams twice a day for 4 months for chronic carrier stage. The only caveat is that it should not be used in pregnancy if at all avoidable, and there should be guarded or careful use in children if there is no other alternative. The WHO also recommends cholecystectomy if cholelithiasis is detected on ultrasonography. Why do they do that? Because the gallstone becomes the nidus for formation of salmonella clusters. And these then continue to stay in the gallbladder. They cause continued irritation of the lumen and can even lead to gallbladder cancers. As we move forward, vaccination for typhoid and paratyphoid is strongly recommended and is a part of our universal immunization program. This was a comparison that this very paper did between the two available vaccines. And of note here is that the VI vaccine is parenteral, which is what is normally used. The Typhi 21A is live attenuated. The live attenuated vaccine should not be used in patients who have other immunocompromise like HIV or disseminated tuberculosis or pregnancy. But the VIPS vaccine is safe even in these. The only contraindication to the VI vaccine is children under the age of 2. So I think this is something that should be extended even to adults if our GPs feel that enteric is becoming enough of a problem in our setting. And I think there I would like to stop sharing and
So, thank you, Dr. Nidhi, for these very valid points that you made today. Very interestingly, we've discussed in depth about how innate immunity is also escaped in typhoid. And when you sort of start moving away from COVID, you realize that there are such bigger problems that our country has already been dealing with. When you actually get into the depth of every single disease and all the other communicable illnesses that we have been discussing. So very valid points made today. I would open the floor for questions now. So there are some questions already about azithromycin and cefixime. They say that double antibiotics is being used, and they are asking if you've read anything about it or if you have an opinion about it.
So this very paper, the API guidelines, says that mostly they would go with what is your clinical experience. They do recommend that you should use single antibiotics and follow the clinical parameters of the patient. If the patient is not improving, you may add a second antibiotic. Their take is that as a first line in children, cefixime, and in adults, azithromycin are fine.
I have a point.
Yes, ma'am.
I have been using typhoid dot test a lot, and it was very useful in my practice. But recently in a conference, they said, in Mulchand only, they said the typhoid dot test is a useless test. So
Ma'am, the API guidelines do not say that it is a useless test. In fact, they say that this is the most useful test because it gives you the result in 3 to 5 hours. It is specific for enteric, and you can then rest assured that you're dealing with enteric. However, they also say, the API also says that mostly GPs rely on their clinical experience to diagnose enteric, and most commonly used test in general practice is in fact Vidal, and they in this paper discourage that. They say that Vidal is not, because you have to show rising titers. So they say that Vidal is not diagnostic, but typhi dot is.
Yes, typhi dot was very convenient. I told them also, they said it's not a matter of convenience, it's a matter of diagnosing properly. This is how this.
Ma'am, मैं तो अभी आपको proper guidelines से बता रही हूँ, because I don't directly deal with.
It's okay, I would prefer typhi dot test.
Yes, ma'am. I don't directly deal with enteric. If I see enteric, I refer to a physician. But my take is that typhi dot is diagnostic according to these guidelines. Meenakshi can probably add.
If it is negative, then I don't immediately start the antibiotics. If it is positive, then I do start. I mean, just like
when
that.
can we do
in first week?
typhi dot? When can we do?
In the
Before
first
5 days.
in the first week. In the first week.
After 3 to 5 days, and beyond that. So I would just like to share my own personal experience. My, this is a couple of years ago. My husband had this fever, and I was not in town. And the GPs here, they got the typhi dot done, and they got the Vidal done. Both of them were negative, and they were treating him just like a viral fever, but just based on the clinical suspicion. I got the blood culture done. I was pretty sure this is going to turn out to be typhoid, and it did. On the blood culture, it did show up the salmonella, and then it responded brilliantly to the antibiotics later. So yes, I think typhi dot is a good test to do, but then the clinical history and the clinical suspicion that that is what would lead us into the right direction, in my opinion. And there's another question here, Dr. B, about the typhoid conjugate vaccine is given from 9 months onwards. I don't think there's a question there, but they are asking when should we vaccinate after treatment?
You would need to come in on that, because since it evades immunity, that should not be an issue. Since immune system is not involved in the initial response, vaccination should be as soon as is physically feasible, which would, according to me, be 2 to 3 weeks after the recovery.
Yeah, after recovery, yes.
Madam, usually in the CBC, eosinophilias is not a sign of the enteric fever. We have
no, it isn't. It isn't.
That is a eosinopenia.
It isn't, and that's why I said that this paper says that this is not eosinophils rise or fall is not directly due to the salmonella. It is an associated finding and can be either.
Even we also see without rising without test more than 1:240 in many other conditions also.
Say again.
We many times see the without titer of more than 1:240 in other diseases also, like tuberculosis.
That is why you have to show rising titers. A single Vidal positive titer is not diagnostic of enteric.
There is one conjugate typhoid vaccine which is given only once in lifetime.
No, it's not once. 9 months and then repeat after at the age of
Vaccine.
2 years. Second booster is on at 2 years.
No, this is what the Abbots, you ask them, Abbots, they have told me that this is lifelong, you don't have to give it again.
We have been giving this
Conjugate typhoid vaccine.
Conjugate 9 months and then 2 years.
Conjugate vaccine, it is costing about 1,800 rupees.
Yes.
But he told me that it is to be given only once.
No. Booster at 2 years.
You confirm with the Abbots.
Yes, I've been using for years now.
Okay.
2 doses are for lifetime.
Yes, 2 doses for lifetime.
2 doses at what gap?
9 months and then 2 years.
No, 9 months, then the baby is
At the
9
age
months.
of 9
But for
months?
adult, you can take it today and then after 1 year. Between
Yes.
6 months to 1 year, anytime. Then
At
it
the
will
age of
suffice for lifetime.
we generally give at the age of 9 months and then booster at 2 years.
Dr. Kapoor, you are talking about children.
Yes.
What about adults?
Adults
Yeah.
only 1 dose.
No, 2 doses, even for adults. Between the gap of 6 months to 1 year, maybe around 1 year, a second dose is given. So
You are
that's
talking
the
about conjugate vaccine, na?
Yeah,
Yes.
yeah.
Ah, yes.
आप एबट से एक बार पूछ लेना, आप एबट के रिप्रेजेंटेटिव से एक बार पूछ लेना.
Dr. Meenakshi, can you comment on this vaccine?
The
Vaccine part?
typhoid vaccine is not, it's not the lifetime, the one that we, just give me 1 second. I just want to make sure that the information I'm giving you is absolutely correct. I don't want to make any loose statements. So, just 1 second, please. So what I know is that it has to be given every 2 years, but just give me
Every
1
3.
No,
Sorry.
that is polysaccharide.
After 2 years, every
Yeah,
3 years.
polysaccharide. I'm talking
That is
about polysaccharide.
polysaccharide, not conjugate.
The conjugate vaccine, I'm just telling you. So the polysaccharide, I know that is every 3 years, and I'll just tell you about the conjugate.
Madam, why the quinones is contraindicated in childhood and the pregnancy? Hello.
Hello,
Yeah,
yes.
I didn't get the question. Can you repeat?
Why the quinones are contraindicated in children in the pregnancy?
Why are they contraindicated? Because these are live attenuated vaccines. The
No,
live
no, no, no.
attenuated is contraindicated. The
I
other
am
one is
asking-
not.
I am asking about the quinones compound used in the enteric fever.
Quinolones.
Yes.
Quinolones actually localize to the growing epiphysis. So you would not like to give it to children in the growing age group. In pregnancy, again, it would be the same. The metabolically active bone will take the quinolone and cause problems with the bone growth.
Okay.
Dr. Nidhi,
Ji, sir.
what are the fallacies of different tests? Because with COVID, Vidal is commonly positive.
सर दैट इज व्हाई विडाल के साथ तो हमेशा से सर वो तो पुराना भी है सर भी कहते थे कि राइजिंग टाइटर्स होने चाहिए एंड आई हैव सीन इवन आवर हॉस्पिटल फिजिशियन will kind of initiate treatment for enteric also when they see symptoms which are CLI. So then the ideal would be to use azithromycin. But in Vidal, the biggest thing is that you should have at least 7 to 10 days apart 2 reports showing different titers. And if you do a third one in the third week, it will be exponentially high. So making the decision on one Vidal report is fallacious.
And typhoid in 100% cannot confirm.
Sir, इसमें जो इन्होंने if I go back to that paper that I was telling you of, they say that typhoid is fairly reliable. Now I don't know why ma'am is saying that they were told that typhoid is not reliable. I'll directly read from this paper.
What do you mean
It
by
might be in the COVID era or in among COVID patients. There might be a context to it.
Most of the COVID patients had typhoid positive. So we stopped relying on that.
Maybe it is because of COVID.
You have to rule out COVID in any case. Don't take typhoid positive as enteric.
Ma'am, that is true. That is true. And if we are talking about clinically what appears to be enteric and clinically what appears to be COVID, then we have a clear-cut stem to follow. I mean, if you know that it is clinically COVID, then you would find the exact change in the lymphocytes. I mean, it's opposite in both the cases. But if you are trying to decide whether it is typhoid or enteric, then typhi.dot is not the test, then blood culture is the test, as Meenakshi also pointed out. So no, it says typhi.dot, and I'm reading it directly from here. Typhi.dot, its simplicity, speed, sensitivity, which is 95%, specificity, which is 75%, cost effectiveness, ability to detect antigens as early as 3 days, and a high negative and positive predictive value makes typhi.dot efficient diagnostic tool in resource poor countries like India. Typhi.dot, experts feel, is a viable alternative to Vidal, but is far more reliable. It costs only 300 to 400 rupees, can be done in cases of acute infection, and can be easily prescribed even in tier 3 and secondary cities. So they are saying that it is, in fact, typhi.dot they are recommending. So the caveat of using it is that IgG can persist for more than 2 years after an initial infection. Hence, doing a non-specific typhi.dot cannot differentiate between acute, convalescent, or carriers. Previous infection may lead to false positive. So doing a typhi.m, which is an improved version where IgM specific testing is done within 3 hours, points to acute typhoid infection. So I don't think that they have any doubt as to the validity of typhi.dot or typhi.m to diagnosing enteric. Dr. Kiran has raised her hand.
I've already, you already answered my question.
Okay, ma'am. Okay, ma'am. Typhi.dot पर ही था
Not
ना?
able to put it off. Not able to.
कोई बात नहीं मैम, कोई बात नहीं. जहां से उठाया था ना मैम, वहीं से डाउन हो जाएगा. So I think what this paper says, and I think what is all of your experience also, is that when you suspect enteric, you go for baseline Vidal along with other clinical things that you do. You repeat a Vidal after 1 week. And if you have the facility, you do a blood culture. Blood culture is 100% specific, but maybe false negative if antibiotic has been started early. Typhi.dot, because it gives a quick result. If you're doing a typhi.m, you might be able to detect acute infection. If you're doing non-specific typhi.dot, you will detect G as well as M. So it is not diagnostic. I think the algorithm is quite clear what we would do.
Excuse me, ma'am. Hello.
Ji, sir.
What I've experienced is typhi.dot is not positive before 5 days, and Vidal is not, in any case, antibodies are not formed, so not before 7 days.
So that's why I said 3 to 5 days, but you may be right. You may be right.
IgM does come positive on the 3rd day also. IgG will come later.
Yeah, so that's what this says. And as I said, if I encounter what I think is enteric, I send it to a physician. So your experience is more valuable.
And in any case, if enteric is 1 by 320 positive, there's 100% even after 1 week. So there is no
That's
need
true.
of
That's
treating
true.
it. That's what I.
That is true.
That's true.
So Dr. Sanjeev is asking if fever persists in post-COVID after 10 days, investigation for enteric is required.
Dr. Nidhi,
Ji, sir.
unless the drug control act is implemented in India properly, you cannot rely on blood culture also, because people come after taking so many treatment from the chemist and swag.
Absolutely, sir. Absolutely. And that's why I said that especially in a thing like enteric, जहाँ पर हमारे को timely antibiotic शुरू भी करनी है और antibiotic शुरू करने के बाद blood culture negative भी हो जाएगा, which is the only truly diagnostic test. We have to be extremely careful of what the patient has taken before this. And सर वो केमिस्ट तो ना फटाफट ऑगमेंटिन तो हर एक चीज के लिए मिल जाती है, प्रसाद है.
यही तो स्टॉप करना है. ऑगमेंटिन छोड़ दो, सब एंटीबायोटिक्स. 2 दिन एक केमिस्ट से कोई खाया, 2 दिन दूसरे से कुछ और खाया.
हाँ, ये भी है.
If you are lucky if you even know the name of the antibiotics that the patient has taken. वो कहते हैं कुछ उसमें डाल के दे दी थी. And in fact, there are a lot of, like, you know, in my area, there's a lot of physicians also who are dispensing medicines like that. So,
and all Delhi chemists are giving Nisib plus, dexamethasone, and either augmentin or cefixime. All of them giving on the first day of even 99 fever.
But this is so sad, ma'am, because जो काम कर रहा है अभी, वो भी काम करना बंद हो जाएगा.
तो हमें कुछ करना पड़ेगा ना इसके लिए.
Stress to the government for implementation of the
government
law.
is sleeping over it. We have to start a movement. We have to do something about it.
What can we do?
Ma'am, we can talk to our IMA
public
branch.
Awareness is the best.
Public
awareness is the best.
Yes,
no antibiotics to be given without prescription.
अपनी कंसल्टेशन कम कर दीजिए ताकि पेशेंट सीधा ही आपके पास आए, केमिस्ट के पास ना जाए.
सर, इससे कम मेरे ख्याल से हो नहीं सकती जितनी जीपीसी कंसल्टेशन है. I don't think
HCFI is running free OPDs.
और उसके बाद भी chemist is doing the what they're doing.
मुंबई में नहीं मिलते ऐसे. मुंबई में you can't go and buy an antibiotic like that. Even if you are taking a course, like one of my patients was giving something to the child and she left the prescription here, and then in Mumbai she named the medicine. She had to go to so many chemists, no one gave her. Then in the middle of the night she called me and I had to speak to the chemist and send her the prescription on WhatsApp. So if they can do it there, why can't we do it in Delhi?
We can. I think it requires us to, as doctors, start taking action, and also as a body, जैसे IMA की हमारी branch है, we should be able to do that. I think Dr. Meenakshi has something interesting to share. Typhi bar also. Not something very interesting, but yes, the information that we were looking for. The conjugate vaccine, it's a 1-dose vaccine and 0.5 ml, it's injected intramuscularly. I think I just read that it should not be injected in the intragluteal region. So it should be done in the anterolateral part of the thigh or maybe the deltoid. I don't know why that is. I'll just try to read that up. But yes, it gives you enough protection for at least 3 years to adults, children and infants over 6 months of age. So it has to be given over 6 months of age, and every 3 years probably you would need it if you're living in an endemic area. So every 3 years means it does require multiple dosing, which is the reason why we say.
I think there was, I think Dr.
Yes.
Dr. Arora also had mentioned that we needed every 3 years. So,
Yes.
I mentioned that.
Dr.
Oh, sorry.
Meenakshi, I think
Sorry, your name is-
polysaccharide is to be given 3 years, but
Pankaj Sharma.
conjugate we don't repeat again and again, only 2 doses. That's what in
no, so
pediatrics, so many
this is from Bharat
conferences they have.
Biotech only. What I have shared here. Yeah. So this is the typhoid conjugate vaccine, right? And this is the dosing that they have said. And polysaccharide is every 2 years.
Yeah.
So this one,
polysaccharide is.
this is based on VI antigen. This
Yeah, I
is-
think when this TCV was launched initially, they had said that 2 doses would suffice for lifetime. But once we were discussing, I also got a vaccine dose from my refrigerator and read it. Actually, they are mentioning every 3 years now. So they have changed it probably.
Every 3 years as till growing age, preferably till 18.
Or when
If you're living in an endemic area, yes. So,
Okay.
So I think that's all from us today. We've had a very fruitful discussion, and even though the numbers are less, the questions are still the same. So that's very heartening. A big thank you to Dr. Nidhi and to all those who are present here. If you wouldn't be here, it wouldn't be possible for Dr. Nidhi and me to continue these sessions. So once again, a big thank you to everyone who's joined and for carrying forward the fruitful discussions. We'll be back next week.
I think, Meenakshi, next week we are having our guest speaker talking on blood thinners.
Next
That's
week,
10th?
yes, 10th of October, yes, correct.
Uh,
So that's just an announcement that we can make, so that the next week on Sunday, 10th of October, we are having a guest speaker. They'll be discussing blood thinners. We'll be posting more about that in the in the WhatsApp group, or the other, probably we'll be posting it on the social media as well. So we'll be back then, and next week we'll continue our discussions on fever.